And we are going to talk now about a different type of papillary thyroid cancer, a one that could be quite challenging in clinical practice, the one that we call non-iodine avid differentiated thyroid cancer. So the outline for this presentation will include trends in differentiated thyroid carcinoma. We'll make a brief overview of the classical therapeutic modalities for patients with iodine-avid thyroid carcinoma to compare with whatever is related to non-iodine-avid thyroid cancer. We are going to define non-iodine-avid thyroid cancer. We'll recognize the molecular pathways that are involved in its development. We'll talk about the currently approved targeted therapies for that disease and the future therapies as an introduction to the next lecture. As you know, thyroid carcinomas are classified largely in three different groups. The differentiated thyroid cancers that include papillary, follicular, and heart cell thyroid cancers that represent 95 to 97%, followed by the neuroendocrine tumor, in this case medullary thyroid cancer, that is responsible for 2 to 4% of cases, and finally, anaplastic thyroid cancer that accounts for less than 1% of all primary tumors that originate in the thyroid gland. When you look at the trends of incidence and mortality from 2001 through 2010 in the United States coming from the CR database, you can see that the incidence of thyroid cancer here in red has markedly increased, being the condition, oncologically speaking, associated with the highest enlargement in incidence when compared with other cancers. What it is also interesting, and you can see it in the right side, is that thyroid cancer, apart from being increasing in incidence, is also associated with an increased mortality, which is different when compared with other cancers. For instance, the change in death rate between 2001 and 2010 has been as follows for several examples of cancer. For thyroid cancer, there has been an increase of 13%, while for all other cancers, the mortality has declined by 16%, including decline rates of 28% for lung cancer in males, 33% for colon cancer, and 40% for prostate cancer. What is that? Simply because we have now very effective therapies as well as primary prevention mechanisms for many of them that have been helpful in controlling and curing many patients who have cancer disease. However, this is different from thyroid cancer. As we have described, differentiated thyroid carcinoma from an anatomical perspective could be classified into different groups: localized cancer in the neck and cancer with distant metastases. The localized cancer in the neck represents maybe 90% of cases, and this is cancer that is usually treated with surgery, radioactive ion ablation therapy, and thyroid hormone suppressive therapy, and for most part, these patients exhibit an excellent prognosis. Patients with cancer with distant metastases represent approximately 10% of cases. 33% of them are responsive to radioactive ion ablation therapy and thyroid hormone suppressive therapy, and for most part, they exhibit excellent prognosis. However, 66%, a total of 6% of the whole cohort, are resistant to the above therapies, and this is the group that we are going to focus on in this lecture. As you know, the survival of thyroid cancer, and it's been extensively discussed, depends on the staging of the cancer. When we have patients with stages 1 and 2, the survival rates are almost 100% at 5 and 10 years after initial diagnosis. For a stage 3, they could be a little bit lower, and for a stage 4, which is mainly metastatic disease, you will see that the survival rates could be compromised already by 5 and 10 years after initial diagnosis. From a historical perspective, as we have mentioned before, the ideal treatment, at least for patients who have a papillary thyroid carcinoma that is at least 1 centimeter in diameter, is to have a total thyroidectomy. And you may choose, depending on radiographic findings, the extension on lymph node dissection. We know that radioactive ion therapy is very important. This is the classical paper that published that radioactive ion therapy was effective for the treatment of thyroid cancer. If you look at this, this was not published in a scientific journal. It was published in Life in 1949. similar to what is called now, for instance, in Europe, Hola or Hello. Those kind of journals were the ones that in the US in 1949 published, for instance, that radioactive iodine therapy was for the first time effective in clinical practice. And in this one, what they showed was one patient who presented emaciated with lung metastases, and that patient responded to radioactive iodine ablation therapy. So as you know, radioactive iodine ablation therapy is effective simply because many of these cancer cells, because of the follicular origin, are able to express the sodium iodine importer that, whenever present, will allow the transportation or reuptake from the blood of radioactive iodine. Now, thanks to that, many patients may exhibit a lot of uptake and may benefit from the use of radioactive iodine therapy. Historical description also of what we call thyroid hormone suppressive therapy happened in 1937 at the Ledsomanian lectures by Thomas Dunhill, a doctor who reported 2 children with pulmonary metastases that shrunk with a thyroid extract. That was the first description of thyroid hormone suppressive therapy, and this is based on the fact that the TSH receptor could be a target for therapy, as we have discussed before. As you know, thyroid hormone suppressive therapy, whenever effective, is associated with an improvement in overall survival. In this very nice paper published this year by the National Cancer Comprehensive Network, you can see that patients who have TSH values that were undetectable to subnormal, subnormal to normal, exhibit a better overall survival than those patients who have values that were normal to elevated. But from the historical perspective, it's also important to recognize that in 1953, for the first time, and at MD Anderson Cancer Center, appeared the first description of patients who were not responsive to radioactive iodine ablation therapy or thyroid hormone suppressive therapy. And what the authors concluded was that the results of therapy of thyroid cancer with radioactive iodine therapy could have been disappointed due to the spotty nature of iodine concentration. So this is going to take us in what we define as a non-iodine avid thyroid carcinoma. What is the definition of a non-iodine avid thyroid carcinoma? It could be one of these 4. Number 1, disease that does not reveal iodine uptake in the pre- and post-treatment iodine scan. Number 2, disease that over time has lost iodine avidity. Number 3, disease with iodine avid and non-iodine avid lesions, in which the non-iodine avid lesions have the possibility to be progressive and destructive. Number 4, disease progression despite the use of a high dose of radioactive iodine therapy that, according to guidelines, has been described by many as perhaps a dose higher than 600 millicuries of radioactive iodine therapy. Why is this kind of disease important? It is important because in clinical practice, these patients exhibit a much more aggressive situation, a lower or decreased prognosis when compared with the classical patients who have papillary and follicular thyroid cancer, and you can see it in these 2 graphics. In the left side, you are going to see a Cartesian graphic in which you will see the survival time in months in the x-axis and the cumulative survival located in the y-axis. In the continuous line, you will see patients who have radioactive iodine uptake in the context of lung metastases. And in the broken line, you will see patients who have lung metastases who do not exhibit radioactive iodine uptake. If you look at the survival rates of these 2 groups, of course, the patients who exhibit radioactive iodine avidity have a much better survival at 10 years, with the overall survival rates of 75%, which are 3 times higher than the ones that we see in patients who didn't have radioactive iodine uptake, in which the survival rates are about 25%, with a pronounced and significant difference in between the 2 groups. If you do it in general for patients with metastases here, including not only lung but also bone metastases, you can see that in those who have radioactive iodine uptake, the survival rates are much better than the ones that we have in patients who do not have radioactive iodine uptake. So in summary, the lack of radioactive iodine uptake predicts a poor clinical outcome. Now, the patients who exhibit those characteristics from an epidemiological perspective have some important special qualities. Number 1, these are usually individuals who are older than 40 years of age, and the older we get, the higher the rate or the risk for having a non-radioactive iodine avid thyroid cancer. Number 2, Many of these patients are FDG PET positive. If you look at patients with thyroid cancer, as it has been described before, most of these cancers are well-differentiated carcinomas, and for most part, the FDG PET is going to be normal. However, in patients with this kind of cancer, the PET scan has a big chance to be positive. Number three, many of these patients, when they present with lung metastases, they will have initially a diagnosis or on the follow-up, the classical development of a macronodular disease, meaning disease that is characterized by radiographic nodules that are bigger than 1 centimeter in size. So that implies that they have apparently a more aggressive clinical outcome in clinical presentation. Now, for these patients, we cannot rely a lot in the thyroid hormone suppressive therapy because they are not responsive to it, and we cannot rely on radioactive iodine therapy. So we have to look for abnormalities from a molecular perspective that are responsible for the development of this particular type of papillary thyroid cancer. So we have to look at the signaling pathways that are involved in the development of differentiated thyroid cancer. As we have described before, these are signaling pathways that are modulated by tyrosine kinase receptors, and the tyrosine kinase receptors that participate here, amongst others, include the epidermal growth factor receptor, the c-MET receptor, the fibroblast growth factor receptor, the vascular endothelial growth factor receptor, in particular number 2, and all of them will have the capacity to activate two different pathways. One, the MAP kinase pathway that starts with RAS, following by the activation of BRAF, MEK, and ERK, and the other one, the PI3 kinase pathway, in which we have the activation of RAS, followed by activation of PI3 kinase and AKT. The activation of these two pathways under abnormal conditions will increase the proliferation of cancer cells, will induce, in many of these patients, a dedifferentiation of the cell, making it more primitive and less avid for radioactive iodine therapy and less avid for thyroid hormone suppressive therapy. In these pathways, we may see mutations that are responsible for cancer, and the mutations that are responsible for cancer happen either in BRAF in red, RAS in red here, and the rearrangement that we call red PTC. So these three are currently the most important mechanisms responsible for the development of thyroid cancer in clinical practice, and this is important to recognize that these are mutually excluding genomic alterations. What is the meaning of that? That if a thyroid cancer cell exhibits mutations in BRAF, that thyroid cancer cell is not supposed to have mutations in RAS or red PTC, and that simply indicates that this is a mutation that is really important for the development of cancer. In the same way, if the cancer cell has mutation in RAS, the other intermediate agents in the pathways are supposed to be normal. If you have cancer patients who have a red PTC rearrangement, most likely you are not going to see abnormalities either in RAS or BRAF. So that's an important aspect from the molecular regulation. Now, what are the most common mutations that we see in clinical practice? This is coming from the Genomic Atlas in the United States of patients who have papillary thyroid carcinoma. Currently, the most common mutation is the BRAF gene mutation that is observed in about 62% of all these patients. This is followed by mutations in the gene RAS, which happens in about 14.1%, and we see the rearrangements red PTC in about 6.3% of our patients. An interesting aspect is that in a substantial number of patients, we don't really know what are the mutations that are responsible for this type of thyroid cancers, but this knowledge is considered to us very important because it may predict to us on how we are going to treat a disease like a differentiated thyroid cancer that is not sensitive to radioactive iodine therapy. There are two therapies that we currently use for this disease, and they include anti-angiogenic therapies and one that I'm going to discuss that is still in research, which includes the medications that are going to make these tumors differentiated into iodine uptake. Let's talk about anti-angiogenic therapies. When we go back to the pathways that are involved in the development of thyroid cancer, the receptors here that I mentioned before, the vascular endothelial growth factor receptor, the fibroblast growth factor receptor, the c-MET receptor, and the epidermal growth factor receptor, all of them are involved in the angiogenesis of the cell. And that's important because it's going to feed the tumor. So you may wonder, what about if we inhibit one or two or all these receptors in order to decrease the angiogenesis and perhaps to have an impact on the disease. And yes, currently, we have 2 medications approved by the FDA that can help us in doing that. These medications work in this particular area. They inhibit the vascular endothelial growth factor receptor number 2, that is important for sorafenib, and inhibition of the vascular endothelial growth factor receptor number 2, as well as the fibroblast growth factor receptor, which is important for Lenvatinib. These 2 drugs have been approved over the last 2-3 years for the treatment of differentiated thyroid cancer. And why they've been approved? They've been approved because these patients didn't have any therapeutic modalities before, and they clearly demonstrated in phase 1, phase 2, and phase 3 clinical trials that they could be effective in these patients with minimal or tolerable side effects depending on the dose that we use for these patients. So let's talk about sorafenib. Sorafenib is a very interesting medication. This is a pure anti-angiogenic agent. If you look at this drug, and if you look at what I described before, and I'm going back, this is a drug that works here, but doesn't work in particular in any of these genes, with the exception of BRAF. But what clinical trials have shown to us, and we'll see it later, is that for sorafenib activity, it doesn't matter if the patient has a BRAF mutant tumor or not. Sorafenib seems to be a non-selective anti-angiogenic drug. Where is that information coming from? The information is coming from this particular clinical trial. This is the Decision phase 3 clinical trial. This is a clinical trial that was very well designed. This is a randomized clinical trial in which 417 patients were randomized from October 2009 through July 2011. These patients had locally advanced or metastatic disease that was refractory to radioactive iodine therapy. And the patients had disease that was progressive. That progression was demonstrated by RECIST criteria based on conventional radiographic studies. As per the trial design, these patients didn't have any prior chemotherapy, targeted therapy, or thalidomide, and the patients were randomized 1-to-1 to one arm with sorafenib for 100 milligrams twice daily, or placebo orally twice daily. The primary endpoint, progression-free survival, and secondary endpoints included evaluation of overall survival, response rate, safety, as well as time to progression, disease control rate, duration of response, and some pharmacokinetical aspects. What it was important from the Decision clinical trial is the most important part related to the primary endpoint, the progression-free survival. In this graphic, you can see how the drug worked in that particular regard. In this table, you will see the placebo group in blue, and you will see the sorafenib group in red. Patients who have or who were treated with sorafenib exhibit a median progression-free survival of 10.8 months, while patients who were treated with placebo had a median survival of 5.8 months. The difference in between the two groups was considered significant. Now, because of that, the drug was approved by the FDA. Now, is this a very potent drug as an anti-angiogenic medication in the treatment of thyroid cancer? Well, in reality, when compared with others, may not be that potent, but it's important to recognize some aspects on it. In the right side of this slide, and I'm going to guide you here because some of you may not be familiar with this, what we have here is the objective response rate measured by RECIST 1.1 in all these patients. In blue, you will see the placebo, and in red, you will see the sorafenib group. We consider a partial response whenever we observed in our patients a reduction in tumor size when compared with baseline of about 30% of tumor size. When you look at sorafenib, there was a reduction that was bigger of 30% in approximately 12.2% of our patients. That was only seen in one patient in the placebo group. Other patients had what we consider a stable disease, but when you look at the waterfall, in reality, many patients, although having a stable disease, they were having some reduction in the size of the tumors. So sorafenib is a drug that has anti-angiogenic properties with oncological properties associated with a decreased size in tumor, as well as a stabilization of disease with impact in the progression-free survival later. When you look at overall survival, however, it didn't reach a median overall survival rate for sorafenib for placebo. So we are not able to tell yet that sorafenib is a drug that is able to improve the survival of all these patients. An interesting aspect is that these patients were evaluated for BRAF and RAS mutations, and we compare sorafenib versus placebo, and as you can see here, when you look at the ratios, there was no really difference in between the presence of BRAF mutants and a response to sorafenib or not. In other words, the presence of a BRAF mutation does not predict that the patient will respond to sorafenib or not, and that happens also for mutations located in the gene RAS. So from the molecular perspective, we believe that the answer to how to find a good treatment for our patients is by looking at the molecular targets and likely identifying a drug that matches that particular molecular target. Sorafenib so far is not an example of that, similar to what happened with many other medications. However, because it was the only drug that has proven effectiveness, it was approved by the FDA approximately 2 years ago. Then let's go to the newest medication in this particular group of drugs, Lenvatinib. This is a very interesting medication. Just to remind you, this is an anti-angiogenic drug that has also activities on the fibroblast growth factor receptor, and since the very beginning, Lenvatinib was associated with an excellent response in patients who have thyroid cancer that was not avid for radioactive avidity. So these are the reports of the phase 1 clinical trial with Lenvatinib. In this graphic, you will see many patients with different types of cancers. You have to remember that phase 1 clinical trials are basket trials. They are trials that are looking to see the side effects associated with a particular drug, and they are tested in patients who have different types of cancer. While in this phase 1 clinical trial, some patients with thyroid cancer, here represented in the dark blue color, were treated with Lenvatinib, and surprisingly, they represented the majority of cancer patients in this cohort that responded to the drug in a substantial manner according to RECIST 1.1. The drug was associated with hypertension, proteinuria, fatigue, and gastrointestinal symptoms such as nausea, vomiting, and diarrhea, amongst others, and the tolerable dose was recommended to be 24 milligrams daily, which is the drug that is currently approved for the treatment of thyroid cancer in clinical practice. Now, based on this report from phase 1 that was mainly looking at safety, we went into a phase 2 clinical trial with Lenvatinib that was looking at a good response or a determinant of a good response in clinical practice to see how effective the drug may be. And in this graphic, you are going to see all the patients involved in the clinical trial. This is a waterfall graphic in which each line, each bar represents one patient. And you will see that in green are patients who exhibit partial responses, in other words, a reduction of tumor size by 30% when compared with baseline, patients with a stable disease who have values in between baseline and a reduction of 30% here in yellow color, progressive disease in red. These were patients in whom new lesions appeared or who exhibit an enlargement of more than 20% when compared with baseline. And as you look at this graphic, most patients exhibit a reduction of tumor size, and some of them was a stable disease, but in big majority, we saw partial responses, which is much bigger than what we saw in sorafenib studies. That really caught our attention. We have to be careful because this is a study that is not comparing with sorafenib, but the numbers from a clinical experience really called our attention. So we went into a phase 2 clinical trial phase 3 clinical trial with Lenvatinib. This one was a randomized, double-blind, phase 3 clinical trial that included 392 patients. These patients needed to have evidence of progression of disease for a period of time of 13 months. They were refractory to iodine therapy. They had measurable disease in order to apply RECIST, and they could have had treatment with one or anti-angiogenic therapy or another target therapy. The drug was proven in Europe, in North America, and it was stratified based on age, in between 65 years of age and older, and less than 65 years of age. Patients were randomized 2-to-1. Some patients received Lenvatinib, and they were compared with placebo. The The primary endpoint was progression-free survival. The secondary endpoints were objective response rate, overall survival, and safety. And Leif, thank you very much. Thank you. And these are the results that we observed in the clinical trial. So let's look at the patient characteristics. There was a similar distribution in genders in between Lenvatinib and placebo. In regards to the region, there was a similar distribution in between Europe, in between Lenvatinib and placebo, as well as North America for Lenvatinib and placebo. When you look at the performance status of these patients, many of these patients had very good performance status, ECOG of 0 to 1. Some patients were allowed performance status of 2 to 3. There were no statistical significant differences in that regard in between Lenvatinib and placebo. As I mentioned to you, many patients were treated before with sorafenib or other anti-angiogenic therapies. There was no difference in between Lenvatinib and placebo. Some patients were allowed to be treated with anti-angiogenic therapies before, and there was not also difference in between the two comparative groups. When you look at the histological characteristics, papillary thyroid carcinomas were similar in between the two groups. Poorly differentiated thyroid cancers were similar, and follicular thyroid cancers were also similar. And the study also looked at the type of metastatic lesions, whether they were only bone metastases or just pulmonary metastases, and there was no difference in between the two groups. The study looked at this because in clinical experience, it seems that bone metastases may work or may respond in a different manner to lung metastases to some of these therapies. So what are the results of this study? The primary endpoint was achieved very fantastically by the drug of Lenvatinib, as you can see here in this graphic. In blue, you will see patients who were treated with Lenvatinib. In white, patients who were treated with placebo. At 2 months after initiation of therapy, you can see a separation of the curves, and the separation of the curves was quite dramatic. The median progression-free survival was for Lenvatinib 8.3 months, while for placebo was 3.6 months. Very interesting difference in between the two drugs. When you look at the progression-free survival, depending on the use of prior anti-angiogenic therapy, in patients who were naive to anti-angiogenic therapy, there was an improvement in survival. And in patients who were treated before, also with anti-angiogenic therapy, that improvement in progression-free survival was also noticed. In other words, the use of other anti-angiogenic medications did not prevent a drug like Lenvatinib to work in these patients. In regards to tumor localization or tumor location, patients who have baseline metastases in the lungs, they exhibit an improvement in progression-free survival when compared with placebo. Patients who didn't have bone metastases in the lung, but in other places also exhibit improvement in progression-free survival when compared with placebo. And that happened also for patients with bone metastases in which the progression-free survival was markedly improved over time when compared with placebo, as you can see in this graphic. It was very interesting from this study, what you will see here, the progression-free survival of these patients improved regardless of the histology. So this drug works very well in papillary, in poorly differentiated, and in follicular thyroid carcinomas. The drug works independently of the number of baseline metastases. So you may have a small number of metastases, you may have a large number of metastases, a moderate number of metastases, and the patients still exhibit a favorable or positive response to the drug when compared with placebo. And the response was also independent of the tumor burden, regardless of the tumor burden, a small tumor burden disease, big tumor burden disease, the patients responded better when compared with placebo. In regards to the objective response rates, as you can see in this graphic, patients who were treated with Lenvatinib exhibit a complete response in about 2% of patients. This is quite unique of this particular clinical trial. It is one of the very few situations in which we see a complete response, radiographically speaking, in someone who has a tumor, a solid tumor. Placebo patients didn't have complete response. Partial responses were quite high. We are talking about 63%, while in placebo we only saw 2%. A stable disease happened in 15% of these patients, and yes, some patients had progressive disease, But overall, the response rate of all these patients was very high, higher than 90%, which is much higher than whatever we have seen with other medications before. So this one was quite interesting, and because of all these clinical characteristics, the FDA said, yes, this is a drug that is important in clinical practice, and we are going to approve it for the treatment of a non-iodine avid thyroid cancer that is progressive. Now, when you look at the patients who had complete responses, it is interesting that they have some histological characteristics. They had very challenging conditions. Heart cell cancer was present in one. There were 2 patients who presented with insular thyroid carcinomas. As you know, these are rare cancers in clinical practice, and they could be quite aggressive whenever appear, and one patient had a clear cell carcinoma. In these patients, radiographically speaking, there was disappearance of the disease. Now, I have to clarify here, although the paper was published in the New England Journal of Medicine, there was one point that I think was missed by the reviewers. Although these patients, radiographically speaking, the tumors disappeared, they still have evidence of thyroglobulin in plasma. So I'm not really sure if the thyroid cancer cells were really cured or not. Most likely they were not. Therefore, they needed to continue on treatment. So to talk or to consider cure rates in these patients is something that we still have to evaluate with future studies. Now, the starting dose of these patients was 24 milligrams, which was the one that was identified in the phase 1 clinical trial. The median time to objective response was really fast, approximately 2 months, but the median time to first time dose reduction was 3 months. In other words, although the drug was quite effective, the drug is not an easy medication to use in clinical practice, and the most important side effect to consider was hypertension. These patients had very difficult to control hypertension that responded better to antihypertensive medications as well as dose reduction of Lenvatinib. In regards to overall survival, this is a very interesting analysis. The median overall survival for Lenvatinib seems to be longer than the one that we see in the placebo group. Since the very beginning, is one of the very first examples in solid tumors associated with tyrosine kinase therapy in thyroid cancer that is associated with improvement in overall survival, reason why our new guidelines from the National Cancer Comprehensive Cancer Network consider the use of Lenvatinib as the first-line therapy for the treatment of thyroid cancer above sorafenib. So that's an interesting part. Now, this is complicated. If you have any questions, please let me know, because I'm going to change the topic to another group of drugs that I think are a great promise in our clinical practice. So let's move into the restoration of the iodine uptake. There are 2 medications here that are quite interesting. One of them is Selumetinib. The other one is Dafrafinib. I'm going to discuss the findings that we have on Selumetinib. Selumetinib is a very interesting medication. This is a MEK inhibitor. It works in the MAP kinase pathway. From an oncological perspective, the results were disappointing in the sense that the tumors barely decrease in size, and many patients apparently exhibit disease progression. However, when the drug was studied in animals looking for the restoration of radioactive iodine uptake, animals exhibit an increase or a restoration of the radioactive iodine uptake, and you can see it in this particular graphic that I think is better to show in humans for you to have a better understanding of how Selumetinib works. This is work that has been done brightly by James Fagan and his group at the Memorial Sloan Kettering in New York. And this is a study in which we are looking at the responsiveness of radioactive iodine therapy. I'm just going to show you one patient of that particular cohort. This is a patient in whom you see an iodine scan. This is at baseline. The patient had lung metastases, and you don't see anything in the lungs. The patient was treated with Selumetinib, and after some time of therapy with Selumetinib, you can see the increase of iodine uptake in that particular scan. They did iodine PET scan, and you can see that there was some uptake here, and the uptake markedly improved after Selumetinib. You can see that in the lungs. You can see also that in some of the bone metastases that the patient had in the skull and the head area, as well as in the pelvic areas. It was very interesting because in this particular study, they evaluated, this is a pilot study, They evaluated 20 patients with radioactive iodine refractory papillary thyroid cancer or poorly differentiated thyroid cancer. They had evaluations with iodine 124 PET before and after 5 weeks of selumetinib therapy. 12 out of 20 of these patients, 60%, had an increased tumor uptake. 8 achieved a calculated radiation dose of more than 2,000 centigrades, and of all these 8, 5 had a partial response and 3 had a stable disease when the disease was initially progressive. And something that was very interesting from this study is that it seems that the presence of RAS mutations predicted a better response to radioactive iodine therapy. Of course, this is something that we have to prove in a much larger study in clinical practice. If we see this from a different perspective, selumetinib, you can see here how was associated with an increased iodine uptake. In the left side of this table, you will see patients in red after selumetinib, in blue before selumetinib. You see that there is some uptake by PET scan before, and when you use selumetinib in some of these patients, the uptake markedly increased. And in other patients who didn't have absolutely any uptake, the use of selumetinib was associated later with an increase of radioactive iodine uptake. So that's quite interesting because the drug, as I told you, from an oncological perspective, seems to be quite weak. But if we use it for only 5 weeks, perhaps the side effects are acceptable because it's a shorter period of time that there's the use of longer therapies such as Lenvima or Lenvatinib or Sorafenib in clinical practice, and we may be able to convert a non-iodine avid thyroid cancer in a radioactive iodine avid thyroid cancer, which is much more differentiated and associated, as we have described before, with a much better prognosis in clinical practice. So where are we? So this is just an introduction to the next slide. There are several medications that are currently in clinical trials. We have to listen to whatever comes in the news, because all these clinical trials are giving us a lot of interesting information. I am just going to mention the names of all these drugs. We have BRAF inhibitors, such as Vemurafenib, Dafrafinib, and Sorafenib. We have a RAS inhibitor, such as Tipifarnib. We have red PTC inhibitors, Sorafenib, Sunitinib, Vandetanib, Motesanib, Cabozantinib, and Lenvatinib. We have medications that are purely anti-angiogenic, such as the ones that you see there, plus 2 that we haven't mentioned, Axitinib and Pazopanib. We have a c-Met inhibitor, Cabozantinib, which in phase 2 and phase 3 clinical trials is showing excellent responses too. We have an EGFR inhibitor such as Vandetanib, and another one in clinical trial, Gefitinib. We have a MEK inhibitor, Selumetinib, and finally the group of the mTOR inhibitors such as Everolimus and Temsirolimus, which in my clinical view is perhaps the weakest group of medications for the treatment of all these patients. I think our hopes are mainly focused on medications such as Dafrafinib, Selumetinib, and very potent anti-angiogenic drugs such as Cabozantinib, Lenvatinib, and Pazopanib. So in conclusion, patients with iodine-resistant thyroid cancer exhibit a decreased overall survival. These patients may benefit from targeted therapies. For the most part, at least with our current knowledge, genetic mutations do not predict a response to most therapy, but the clinical findings have clearly demonstrated the value of all these medications. And with that slide, I finish this presentation. This is my last lecture in this very important meeting. I just want to describe to you how MD Anderson Cancer Center is in some ways a very big institution. We are looking for collaborations with many places around the world. We want to know and learn from all of you how you practice and how you do things. This is our basic science building. This is the hospital. Here we admit many of our patients. The faculty center, the old one, and the new one, this is where my office is located, and several of the outpatient clinics are located in this area, and this area in what we call the Texas Medical Center in Houston, Texas. From there, as usual, at your service, and thank you very much for this very nice invitation to Cyprus. Thank you.